Hey, today's focus is going to be to get myself into the recording or slash streaming state. I'm slightly a nerd and not in the zone that I was for the previous two sessions, but the idea is that today I will be trying to psych myself into uh, making the next few hours productive. And this has to be the most, because I don't have a pre planned script or anything in mind, this has to be the most stream like situation today where I like free flow and I react to whatever comes in mind. And what came to mind is understanding the causes of pain. Sorry. Okay. Understanding the causes of pain. We're going to get into it.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through pain management. And you can find written notes on this topic at ZeroToFinals.com/pain management or in the Anesthetics and ICU section of the Zero to Finals surgery book. So let's jump straight in. The International Association for the Study of Pain, or IASP, publishes a definition of pain, and this is from 2020. Their definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage.
Mm-hmm.
It's important to distinguish between two categories of pain: acute pain, which is a new onset of pain, and chronic pain, where the pain has been present for 3 months or more.
This is your brain when you're struggling to focus.
Tissue damage is a component, is something I did not know. I think if I was asked previously, what do you think is the definition of pain? I would say something that affects your physical and emotional state or well being negatively. So that would be considered pain. It strikes me that the actual definition, as per the organization, International Organization of Pain or something, is that tissue damage is a necessary criteria. Mhm.
This section aims to help students prepare for exams and should not be used as a reference for managing pain in patients. Let's talk about some basic pain physiology. There are two aspects to the experience of pain: the sensory experience and the affective experience.
Uh,
The sensory experience refers to the sensory signal transmitted from the pain receptor. An example of this is when the patient says, "It's a sharp sensation like a needle." The affective experience is the unpleasant emotional reaction to the pain. And an example of this would be when a patient says, "It's excruciating, I can't bear it." Pain is supposed to indicate underlying or potential damage to tissues, but it can occur without any tissue damage.
mhm.
The physiology of pain is quite complex, and there's still a lot that's not fully understood about the experience of pain. Pain is subjective, meaning that when someone indicates they're in pain, we need to accept their experience, even when there's no apparent underlying cause. Pain threshold refers to the point at which a sensory input is reported as painful. For example, different temperatures can be applied to the skin to measure the point at which heat is interpreted as pain. If someone experiences pain at a higher temperature, this indicates a higher sensory threshold for pain, or a higher pain threshold. Allodynia refers to when pain is experienced with sensory inputs that do not normally cause pain, for example,
No.
light touch of the skin.
Allodynia. Allodynia, okay. Pain with normal sensory inputs, okay. Allodynia.
This indicates
Something with hedonia. Uh, what I was thinking was there's like a NIA. Um, suffix attached to names associated with pain. Is there a truth to that?
A low pain threshold where even normal sensory inputs are interpreted as pain. Pain tolerance is different to pain threshold. It's more difficult to define pain tolerance and generally refers to a patient's response to pain. One person may experience pain and think little of it and carry on with their activities as normal. Another person may experience a similar pain but worry that it indicates a serious underlying illness, take time away from work, and seek medical investigations and treatment. Pain tolerance varies massively between individuals and is influenced by many biological.
When I search something, does it appear in the history? No, not going to do that. But yes, there is truth to the idea that suffixes ending with nia are used in medical terms related to pain, though the specific most common suffixes are algia or odynia or dynia. These terms are derived from Greek roots referring to pain or suffering. The pain related suffixes ending in ia. Algia. Algae means pain derived from Greek algos. Examples: neuralgia, nerve pain, neuralgia, nerve pain, arthralgia, joint pain, cephalgia, headache, myalgia, muscle pain. Okay. ODYNIA. DYNIA means pain derived from Greek cannot ODYN and has something a tilde on the head of E. Examples: arthrodyna joint pain, odynophagia, painful swallowing, gastrodynia, stomach pain, mandibulodynia, jaw pain. LGA means sensitivity to pain, or algesia means sensitivity to pain or pain. Examples: hypergelsia, increased sensitivity to pain, analgesia, lack of pain, analgesia, lack of pain. Other related suffixes: AGR, excessive pain or severe pain, such as cephalagra, severe headache. I, a general suffix denoting a condition or diseased state, which, when combined with pain, roots from the medical terms. In summary, while the NIA itself is in the primary suffix, ALGIA, ODYNIA are standard medical suffixes for pain that fit the description.
Psychological and social factors. At the most basic level, pain receptors, which can be called nociceptors, at the ends of nerves detect damage or potential damage to the tissues. Nerve signals are transmitted along the afferent nerves to the spinal cord. Afferent sensory nerves that transmit pain signals are part of the peripheral nervous system, and they're called primary afferent nociceptors. Two groups of nerve fibers transmit pain. C fibers, which are unmyelinated and have a small diameter, transmit signals slowly and produce dull and diffuse pain sensations. A delta fibers, which are myelinated and a larger diameter, transmit signals fast and produce sharp and localized pain sensations. The signal then travels to the central nervous system, up the spinal cord, mainly in the spinothalamic tract and the spinoreticcular tract, to the brain where it's interpreted as pain, mainly in the thalamus and the cortex. The main sensory inputs that generate a pain signal are mechanical, for example, pressure, heat, and chemical, for example, prostaglandins. Having gone through that basic physiology of a pain signal being generated and transmitted to the brain, it's actually more complicated. When directly measuring activity in the peripheral afferent sensory nerves, pain can be experienced without any activity in the primary afferent nociceptors. Equally, activity in
What I can do is tell Gemini, go to Gemini. Go to Gemini here and go to read. Google Gemini here. And the idea is that I'm going to start the same thread here so that when I need to show people what I am talking about, what I'm reading, I can just read through here instead of going, instead of just reading and not, instead of just reading and it not being shown on the screen.
The primary afferent nociceptors can be detected without the patient experiencing any pain. Essentially, patients can experience pain without any clear nervous signal that should cause pain. And equally, patients with a nervous signal that should cause pain may not experience any pain. Referred pain refers to a pain experienced in a location away from the spinothalamic tract and massively between individuals and is influenced by many biological nociceptors. At the most basic level, pain receptors, which can be called nociceptors, at the ends of nerves detect damage or potential damage.
Noise. Pain receptors and noise receptors. Okay, what I need to do is hammer down on like how, for that we need to go to there. The treatment pain tolerance varies massively between individuals and is influenced by many biological, physiological, and social factors that, in most basic level, pain receptors, at the most basic level, pain receptors, which can be called noise receptors, at the end of nerves detect damage. At the end of nerves detect damages, or not just damage, or potential damage to the tissue. Nerve signals are transmitted along the afferent nerves to the spinal afferent nerves to the spinal cord. An afferent nerve or sensory neuron. Afferent nerve is a sensory neuron carries nerve impulses towards the central nervous system CNS, the brain and spinal cord from sensory receptors in the body, transmitting information like touch, pain, temperature, and internal organ status actually for processing. These nerves are crucial for sensing the external and internal environment, acting as the body's sensory input system, and are often called sensory nerves. So, afferent nerves are basically sensory nerves. Afferent nerves. What we do is the new docs. You name it. Notepad. Afferent nerves and sensory nerves basically is my discovery so far. Are often called the sensory nerves. Key characteristics: direction from periphery, body and tissues, receptors to CNS to brain, direction, sure, why not? Okay. Function: sensory input detects stimuli, pain, touch, sting, actually not sting, sight, sound, etc. Type: sensory neurons, fibers from skin, somatic afferents and organs, visceral afferents. Afferent versus efferent. Arrives at the CNS, exits the CNS. Okay. So there are like two types of things. Afferent arrives at the CNS from the body. So this is the body and it is going to the brain. This is afferent with an A, and the signal that exits the body and goes out as a motor output or just an output in general is the efferent, E, with an E. Types of afferent fibers: somatic afferent, carry sensations from skin, touch, pain, temperature, etc. Visceral afferent carry sensations from internal organs, polylocalized pain reflex signals. Special afferent transmits sensory information from vision, hearing. Special afferent basically. And this. Touch. Okay. Just this portion, okay. Just this portion. Somatic afferent carry sensations from skin, muscle, joints, touch, pain, temperature, etc. Visceral afferent carry sensations from internal organs, polylocalized pain, reflex signals, etc. Special afferent transmit sensory information for vision, hearing, taste, smell via special cranial nerves. Okay.
Damage to the tissues. Nerve signals are transmitted along the afferent nerves to the spinal cord. Afferent sensory nerves that transmit pain signals are part of the peripheral nervous system, and they're called primary afferent nociceptors. Two groups of nerve fibers transmit pain. C fibers, which are unmyelinated and have a small diameter, transmit signals slowly and produce dull and diffuse pain sensations. A delta fibers, which are myelinated and a larger diameter, transmit signals fast and produce sharp and localized pain sensations. The signal then
C fibers, which are myelinated, have a small diameter, transmit signals slowly, and produce dull and diffuse pain sensation. Delta fibers, which are myelinated and larger diameters, transmit signals fast and produce sharp and localized pain sensations. The signal then travels to the central nervous system. Okay.
travels to the central nervous system up the spinal cord, mainly in the spinothalamic tract and the spinoreticulator tract, to the brain where it's interpreted as pain, mainly in the thalamus and the cortex. The main sensory inputs that generate a pain signal are mechanical, for example, pressure, heat, and chemical, for example, prostaglandins. Having gone through that basic physiology of a pain signal being generated and transmitted to the brain, it's actually more complicated. When directly measuring activity in the peripheral afferent sensory nerves, pain can be experienced without any activity in the primary afferent nociceptors. Equally, activity
Multiple parts of the body, for example, the in spinal cord, when does it start? So 5:40. In the primary afferent noise receptors equally, activity in the primary afferent noise receptors can be detected without the patient. Okay. Though the basic physiology of a pain signal being generated and transmitted to the brain is actually more complicated when directly measuring activity in the peripheral afferent sensory nerves, pain can be experienced without any activity. So the idea is that in the peripheral nervous system, peripheral afferent sensory nerve, peripheral afferent sensory nervous pain in the nerves. So peripheral nerves, these our like bodies and outside peripheral regions are inundated with nerves. So these nerves can feel pain even though there is no pain. Is the idea can be experienced without any activity in the primary afferent noise receptors. Okay, sensors can feel pain even though there is no activity in the noise receptors. So what is the distinction between sensories? Okay, I'm just going to okay, we are back to recording. So what I was doing was this phenomena where we were discussing few wait, yes. Sometimes we feel pain even though there is no underlying reason to feel pain. So there is like a disconnect between the sensors and basically the receptors. So sensors sense pain even the receptors are not receiving any painful experience from the external world is the issue. The disconnect, as it is pointing out here, is signal versus feeling. The text highlights two paradoxical scenarios. The challenge or common sense view of injury pain without nociception. And this is a key pronunciation and key term, nociception. Pain without one is basically like this. This is like an alarm going off when there is no intruder. This happens in chronic pain conditions or phantom limb. And a phantom limb phenomena is when you do not have a limb but you feel sensations in the limb. The reason it happens is because the sensors from your face and your limbs are located in the same area of the brain, and when someone touches your face even though you do not have a limb, you feel like someone is touching your limbs and you feel sensations. That is like the phantom limb phenomena, I think. The brain generates the sensation of pain based on memory and expectations and central nervous system sensitivity. Even if the peripheral nerves, the ones in your skin and muscles, are quiet, so peripheral nerves are quiet, but you still feel like pain. And hence it is called pain without nociceptions. Nociception without pain. This is the wounded soldier phenomena. A person might have a significant injury. The nerves are screaming danger, but because of adrenaline focus or the brain's natural filtering, they feel absolutely nothing at the moment. So nociception is basically the actual underlying cause of a pain. Like if there is nociception, there is pain. Yes, this is the definition. Nociception is the physiological neural process of encoding or decoding noxious stimuli, thermal, mechanical, or chemical, that indicate potential or actual tissue damage. Unlike subjective pain, nociception is an objective, measurable nervous system response involving peripheral nociceptors signaling to the spinal cord and brain to initiate protective, reflexive behavior, reflexive or behavioral response. Key distinction: nociception, the physiological process of encoding noxious stimuli; the electrical signal; pain, the subjective emotional experience created by the brain. So there are like two things that are happening. Nociception is the physiological underlying process, physiological process of encoding noxious stimuli. You're encoding the stimuli, registering the stimuli, and the pain is the subjective emotional experience created by the brain. Referred to pain, the crossed wires theory. Crossed wires theory. Refer to pain. The passage mentions referred pain, which is when you feel sensation in a completely different spot from where the damage is. The most common explanations for this is convergence theory. Like your heart and sensory nerves from your skin, like your arm, often travel to the same level of the spinal cord. They plug into the same second order neurons that head up to the brain. The brain is a much more used to receiving signals from the skin than from the heart. When the heart sends distress signal, the brain gets confused and assumes the signal must be coming from the arm. Oh, so this phenomenon. Okay. Why is it so complicated? The several possible explanations the text alludes to usually involve the gate control theory or central sensitization. The gate. There are gates in your spinal cord that can be closed by other sensations like rubbing or bumped elbow, by signals from the brain like don't focus on this right now, effectively blocking the pain, and signal before it reaches to your consciousness. Brain power, your mood, past experience, and even the culture you grew up in changes how your brain interprets these signals, these electrical signals. The takeaway: pain is a brain output designed to protect you, not a direct measurement of how much damage your tissues have sustained. Okay, key takeaway, and I'm going to reiterate this one more time. Pain is a process of your brain output designed to protect you. So I think this is a healthy way of thinking about, or a healthy prism to look into pain, to fully understand pain. It's a good way to understand the topic. The brain's Pain is a brain output designed to protect you, not a direct measurement of how much damage your tissues have sustained. These are two different things, and how much direct measurement of how much damage your tissues have sustained, that is called nociception. I think nociception. I guess you know.
And equally, patients with a nervous signal that should cause pain may not experience any pain. Referred pain refers to a pain experienced in a location away from the site of tissue damage. For example, patients with a heart attack may have pain in their left arm. There are several possible explanations for referred pain, including nerves that may share the innervation of multiple parts of the body, for example, the heart and the arm. Pain in one area amplifies the sensitivity in the spinal cord to signals coming from other areas, and activation of the sympathetic nervous system in response to pain results in pain in other areas. Neuropathic pain is caused by abnormal functioning or damage to the sensory nerves, resulting in pain signals being transmitted to the brain. Typical features suggestive of neuropathic pain are burning, tingling, pins and needles, electric shocks, and a loss of sensation to stimulation of the affected area.
أنا نسمع
Yeah, I should let this
نازحة
play.
من معسكر جباليا.
Let's talk about measuring pain. There are no simple, reliable ways to objectively measure the pain that somebody is experiencing. As pain is a subjective experience, it's measured by asking the patient about their perception of the pain. The two ways commonly used to measure pain are the Visual Analog Scale, VAS, or the Numerical Rating Scale, NRS. The Visual Analog Scale involves asking the patient to rate their pain on a horizontal line, where the left end indicates no pain and the right end indicates the worst pain imaginable. The distance along this line can be measured to get a numerical value to represent the pain, for example 75 mm along a 100 mm line. The numerical rating system involves asking the patient to rate their pain on a numerical scale from 0 to 10, with 0 being no pain at all and 10 being the worst pain imaginable. Pain can also be rated on a graphical rating scale, with a series of faces going from happy to very unhappy. This can
But
be
does it
helpful in
matter?
children or in patients with a
Yeah,
learning
sure, in
disability.
children, but like numerical rating scale
Let's
and the
talk
other
about
one.
the analgesic ladder. The World Health Organization, or WHO, analgesic ladder was originally developed to help manage cancer-related pain. It's also often used for acute and chronic painful conditions. The idea is that patients with mild pain start on the first step of the ladder, and when the pain is more severe or does not respond to the lower steps, higher steps on the ladder can be used until the pain is adequately managed. There are 3 steps to the analgesic ladder. Step 1 involves non-opioid medications such as paracetamol and NSAIDs like ibuprofen. Step 2 involves weak opioids such as codeine and tramadol. And step 3 involves strong opioids such as morphine, oxycodone, fentanyl, and buprenorphine. Other medications may
Okay, so pain medications, non-opioid medications, opioid, paracetamols are non-opioids, NSAIDs, ibuprofen, NSAIDs, and these are terms I should know. So what would be non-opioid? What's an opioid? What is an opioid? Opioids is a class of natural, synthetic, lab-made, semi-synthetic drugs. Wait, what? Are a class of natural, they're natural, synthetic, lab-made synthetic, but still synthetic, or semi-synthetic drugs that relieve pain by binding the receptors in the brain. Okay, I was reading about opioids. Opioids is a class of natural, synthetic, lab-made, semi-synthetic drug that relieves pain by binding to the receptors of the brain and nervous system. Common examples include prescription painkillers, oxycodone, hydrocodone, morphine, fentanyl, and illegal drugs like heroin. They are highly addictive and carry risk of overdose. So when it is say the non-opioid medications, these paracetamol and NSAIDs, AIDs, ibuprofen, these are non-steroid. Weak opioids, codeine and tramadol. Okay. And strong opioids are morphine, oxycodone, fentanyl, bu- buprenorphins.
be combined with the analgesic ladder for additional effect, and these are called adjuvants, or they can be used separately to manage neuropathic pain. And these medications include amitriptyline, which is a tricyclic antidepressant, duloxetine, which is an SNRI antidepressant, gabapentin, which is an anticonvulsant, pregabalin, which is also an anticonvulsant, and capsaicin cream, which is a topical treatment from chili peppers.
Oh,
Imagine
based.
conducting every part of your research platform.
Let's talk about the side effects of analgesia. Medication overuse headache is a common side effect of the long-term use of analgesic medications. The key side effects of NSAIDs, or non-steroidal anti-inflammatory drugs,
Neuropathic pain is a chronic pain caused by damage or dysfunction of the nervous system, nerves, spinal cord, and brain, rather than injury to tissue. So we have organs within our body that detects that serve as the main road of um, travel for signals. So spinal cord would be one of them, and this is what you mean by this is what we mean by hardware. A hardware damage is basically a neuropathic pain. So imagine if you have a bad vehicle versus you're late. Why you're late? Because you're traveling through a bad vehicle, or the road itself that you took is damaged. So that is the distinction, and I think it's a good apt analogy. It is characterized by burning, shooting, or electrical shock-like sensations, often accompanied by numbness, tingling sensitivity to touch. Common causes include diabetes, infections like shingles, stroke, nerve injuries. Management require a multidisciplinary approach, often including specialized medications, antidepressants, physical therapy, or pain management procedure. Key aspects of neuropathic pain. Symptoms: burning, freezing, aching, or pins and needles sensations. Ear pain of normally allodynia. Pain from normally non-painful stimulus like the touch. Numbness or weakness in the affected areas. Common causes: peripheral neuropathy, frequently from diabetes, impact of daily life, it frequent medication, topical treatment, procedure and therapies, etc. Okay.
are gastritis with dyspepsia or indigestion, stomach ulcers, exacerbations of asthma, hypertension or high blood pressure, renal impairment, and
Okay, so
coronary
NSAID, non-steroidal anti-inflammatory drugs, gastritis, stomach ulcers, asthma, hypertension, renal
artery
impairments,
disease,
coronary disease.
heart
Okay.
failure, and strokes, which can all be rarely associated with NSAIDs. NSAIDs may be inappropriate or contraindicated in patients with asthma, renal impairment, heart disease, uncontrolled hypertension, or peptic ulcers. Proton pump inhibitors, for example omeprazole or lansoprazole, are often co-prescribed with NSAIDs to reduce the risk of gastrointestinal side effects, for example acid reflux, gastritis, and peptic ulcers.
Proton pump inhibitor. Point one.
Co-prescribed with NSAIDs, hypertension, or peptic ulcers. Proton pump inhibitors, for example omeprazole or lansoprazole, are often co-prescribed with NSAIDs to reduce the risk of gastrointestinal side effects, for example acid reflux, gastritis, and peptic ulcers. The key side effects of opioids are constipation, skin itching, which is called pruritus, nausea, altered mental state with sedation, cognitive impairment, or confusion, and respiratory depression, usually only with larger doses in opioid-naive patients. Naloxone is used to reverse the effects of opioids in a life-threatening overdose, usually when the patient has respiratory depression. Next, let's talk about the use of opioids in palliative care. Using
Do I need
opioids
these palliative care, opioid conversion, analgesia, pain controlled analgesia, chronic pain, neuropathic pain? Jesus. How many ads are there, man? How many ads? Just go away.
Next, let's go through opioid conversion. The information here is based on the BNF, which gives approximate conversions between different opiates. It's helpful to remember the dose equivalent to 10 milligrams of oral morphine. The conversions are not exact, and patients can respond differently to different opioids.
Don't care, don't
IV,
care.
IM,
Like,
or subcut
no, don't
morphine.
care, doesn't need.
Next, let's talk about post-operative analgesia. Adequate analgesia in the post-operative period is vital to encourage the patient to mobilize, ventilate their lungs fully, reducing the risk of chest infections and atelectasis, and to
Whatever that is.
maintain an adequate oral intake through eating and drinking. Analgesia is usually started in theatre by the anaesthetist, with regular paracetamol, NSAIDs, and opiates if required. For example, regular modified release oxycodone with immediate release oxycodone as required for breakthrough pain. The surgeon may put a local anesthetic into the wound to help with the initial pain after the procedure. Analgesia should be reduced and stopped as the symptoms improve. Next, let's talk about patient-controlled analgesia. Patient-controlled analgesia, or a PCA, involves an intravenous infusion of a strong opioid, for example morphine, oxycodone or fentanyl,
Intravenous
which is attached to a
infusion,
patient-controlled pump. A patient-controlled analgesia involves the patient pressing a button as the pain develops to administer a bolus of the opioid medication. After the patient pushes the button and administers a bolus, the button will stop responding for a set time to prevent overuse. Only the patient should press the button, not the nurse or the doctor. Patient-controlled analgesia requires careful monitoring, and there needs to be input from an anaesthetist and facilities in place if adverse events occur. This includes access to naloxone for respiratory depression, antiemetics for nausea, and atropine for bradycardia. The anaesthetist may prescribe background opiates, for example patches, in addition to the patient-controlled analgesia. Other as-required opioids need to be avoided whilst a PCA is in use. The machine is locked to prevent tampering. Next, let's talk about chronic pain. Chronic pain can be diagnosed when pain has been present or reoccurs in one or more areas over more than 3 months. Some studies suggest up to 50% of adults in the UK are affected by chronic pain. Common areas of chronic pain include headaches, lower back pain, neck pain, and joint pain, for example in the hips or the knees. The NICE guidelines on chronic pain, updated in April 2021, separates chronic pain into chronic primary pain, where no underlying condition can adequately explain the pain, and chronic secondary pain, where there is an underlying condition that can explain the pain. There is a long list of potential causes of chronic secondary pain. A few examples are osteoarthritis, lasting pain after a traumatic injury, for example a bone fracture, migraines, irritable bowel syndrome, endometriosis, cancer, neuropathic pain, for example due to diabetes, nerve impingement, multiple sclerosis, or post-herpetic neuralgia, and complex regional pain syndrome.
The freezing wind cuts
Whoa,
through
how
Grace's
many
fingers,
ads are
leaving
on this
families
video?
desperate
Come
for
on.
warmth. But with your help, we can.
Chronic pain may not improve. Behavioral therapy, or CBT, acupuncture, and antidepressants.
Supervised group exercise programs, accepting and commitment therapy, cognitive behavioral therapy. So CBT is applied here.
For
Antidepressants.
example, Entin. In chronic secondary, patients should not be started on paracetamol, NSAIDs, opiates, pregabalin, or gabapentin.
What would be considered chronic pain? Chronic pain is defined as pain that lasts or recurs for more than 3 months, often persisting beyond normal healing times and affects over 30% of people worldwide. It's a complex, often debilitating condition that stem from injuries, illness like arthritis or cancer, or nervous system dysfunction. Okay. Effective management usually requires a multimodal, patient-centered approach. Chronic back pain, neck pain, and arthritis. Musculoskeletal pain, neuropathic pain caused by nerve damage, often described as burning or tingling. Centralized pain, where the central nervous system amplifies pain. Fibromyalgia. I have definitely heard this name mentioned in house. Chronic, frequent, and daily headache resulting from autoimmune disorder, inflammatory pain, headaches, migraines. Common causes of chronic pain: previous injury or trauma that did not heal properly. Common causes, okay, chronic illness such as cancer, arthritis, fibromyalgia, nerve damage, peripheral neuropathy, infection like post-herpetic neuralgia or shingles. No, post herpetic. No idea what that is. Chronic inflammation.
In chronic secondary pain, analgesia may be helpful depending on the underlying cause. For example, in patients with pain secondary to osteoarthritis, the use of analgesia involves a stepwise approach to control the symptoms. The first step is oral paracetamol and topical NSAIDs. The second step is to consider oral NSAIDs if they're appropriate, and consider co-prescribing a proton pump inhibitor such as omeprazole to protect the stomach. And the third step is to consider opioids such as codeine of the pain and the likelihood that it's neuropathic in nature. Patients are scored out of 10. A score of 4 or more indicates neuropathic pain. There are 4 first-line treatments for neuropathic pain. Amitriptyline, which is a tricyclic antidepressant, can be
I
tried.
don't understand any of that, so what I'm going to do is let this load, and while it loads, what I'm going to do is focus my attention on the different stuff to prefer for a high. Okay, here are the 4 major battlegrounds in pain management history and the core arguments for both sides. So what I'm going to do to finish up this lecture session is focus on the history of pain and pain management. Okay. Number 1, the opioid crisis, relief versus risk. This is the most heated debate in modern medicine. It centers on the balance between the right to feel relief versus the duty to protect from harm. Right to feel relief, right to pain relief, and duty to protect from harm. Arguments for liberal prescribing. Pain as human rights. Pain is the 5th vital sign. Leaving a patient in agony is a violation of the do no harm maleficence principle, non-maleficence principle. Agony is a violation of do no harm. Arguments for strict regulations is the safety crisis. Overprescribing fueled a global addiction epidemic. The risk of overdose often outweighs the benefit of pain reduction. Quality of life. For many with chronic pain, opioids are the only tool that allows them to hold a job or enjoy their family. Efficacy myth. Long-term opioid use can cause opioid-induced hyperglycemia, where the drug actually makes the patient more sensitive to pain over time. Hyperglycemia. Individual autonomy. A competent adult should be allowed to weigh in the risk and choose the treatment. Societal cost. High prescription rates lead to diversion, drugs ending up in the street, impacting public health beyond the individual patient. Okay, so which position I think would which one would be the traditional left position and which one would be the traditional right position? Definitely with the advent of COVID-19, I would think that societal cost is something that the left-wing party, the left-wing political establishment would pick, and individual autonomy would be something that it would be advocated by right-wing people. But then again, I think the opioid crisis, what was it, Bush administration, who came up with the opioid war on drugs? Was it a thing? Well, drugs are not exclusively a conservative project. They became a cornerstone of the conservative policy initiated by Richard Nixon in 71 to combat illicit drug use, and the initiative received bipartisan support initially, but it was heavily intensified and defined by conservative tough on crime rhetoric and policies such as mandatory minimum sentence in the following decades. Origin, while launched by Republican President Nixon, the campaign had broad bipartisan political support early on. Conservative ideology, the initiative came strongly associated with conservative ideology, focusing on the strict law enforcement is a conservative talking about increased incarceration and criminalization rather than rehabilitation, rehabilitation or public health strategy. Key drivers, conservative figures like Ronald Reagan further escalate the war on drugs, leading to significant increase in incarceration rates, and the implementation of the policy like mandatory opiums, which disproportionately affected minority communities. Evolution over time, it developed into a global anti-narcotic campaign with heavy militarization, militarization. Okay, even as recent as the arrest of Maduro was informed by this. The model were biomedical versus biophysiological, not psychological, psycho. The debate is about what pain actually is. The biomedical side, traditional pain is a symptom of tissue damage. If you fix the tissue, with surgery and drugs, you fix the pain. Argument: this model is scientific, objective, and successful for acute injuries like a broken leg. It prevents gaslighting patients by looking for physical proof of their suffering. The biophysiological side, modern pain is a complex output of brain influenced by more cultural and social environment. The argument: the biomedical model fails the argument is the biomedical model fails the million people who have pain without visible damage. Fibromyalgia. We must treat the whole person with therapy and lifestyle changes and not just pills and scalpels. The counter criticism, the critics of this model often argue it's too vague and often used as an excuse by insurance companies to deny expensive physical treatments by saying the pain is physiological. The objectivity trap, visual scales versus brain scans. Because pain is subjective, doctors struggle to measure it. This creates a debate over how we should trust the patient. The subjective view, whether the pain is whatever the experiencing person says it is, existing whenever he says it does. Argument: to doubt a patient's pain is a moral failing. To doubt a patient's pain is a moral failing. Since only the patient can feel it, their words is the only data that matters. The objective viewpoint: we need pain biomarkers, fMRI scans, and blood tests. Argument: human self-reporting is flawed due to memory bias and desire for medication. Having an objective pain meter would allow doctors to treat pain more accurately and prevent drug seeking. If the scan shows no pain activity, but the patient is crying in agony, which one do you believe? Relying on the scans would lead to mass dismissal and real suffering. The infant pain controversy, historical. This is the most powerful historical example of how medical knowledge can be dangerously knowledge. The old argument pre-1980s, doctors believed infants, especially newborns, didn't feel pain because their nervous system immature and they wouldn't remember it anyway. Major surgeries were often performed on babies with only muscle relaxants to keep them still, but no anesthesia. Wow. Modern reality, research proved that infants not only feel pain but may also be infants not only feel pain but may be more sensitive to it because their inhibitory volume down systems aren't fully developed yet. Debate point: this highlights the danger of the medical paternalism when doctors decide what the patient is feeling based on theory rather than observing the patient. Paternalism. But so debate. What I need is something else. Okay. Okay, what are the major debates from conservative and the liberal side on pain management and addiction and stuff related to pain? I want to prepare for a debate and I want to know what the general contention between the two sides are with respect to pain. Conservative side focuses on risk management, physical evidence, and danger of overtreatment. The liberal side, often called patient-centric or numeral, in some academic circles, referring to 1 out of 10 pain scale side, focus on the subjective rights and the sufferer and the moral duty to eliminate pain. Okay, so the idea of we having a moral duty to eliminate pain is a liberal idea, and I like that. The fifth vital sign debate. This is the root of the modern pain controversy. In the 1990s, pain was declared the fifth vital sign, along with heart rate, BP, etc. The argument is that the pain is primarily indicator of health. If the patient says the pain is an 8 out of 10, the medical provider has a moral and professional obligation to bring that number down to 0, usually via paracetamol pharmacological means. The conservative side argues that pain is not a vital sign because it is subjective, not objective. Pain is not a vital sign, okay? By treating a number 0 on a 10 on the scale rather than the patient, doctors were persuaded to overprescribe opioids. They argue that the goal shouldn't be the zero. The goal shouldn't be zero pain, but rather functional movement. Okay, vital sign argument. Addiction, predisposition versus exposure. Conservative side focuses on exposure. They argue that the opioids are inherently addictive hijackers of the brain. The more people you expose these drugs, the more addicts you create. Therefore, the best way to stop addiction is to strictly limit the supply and the number of days a person can take the drug. Take the drug. The liberal side focuses on predisposition versus social discriminants. They argue that that most people can take opioids for short-term pain and stop without issue. They contend that addiction is driven by genetics, trauma, and deaths of despair. Deaths of despair or depths of despair. Restricting drugs only punishes the legitimate pains patients, while the addicts will just switch to dangerous street drugs like fentanyl. The definition of success. What does good outcome look like in a clinic? The liberal side says pain relief. If the patient feels better and the reported pain score drops, the treatment is working. Quality of life is defined by the absence of suffering. Conservative side, failure is function. Success is function, sorry. They argue that the patient can have a pain score of 610 but still be successful if they're walking, working, socializing. They worry that chasing a 0 out of 10 pain score leads to zombification, but the patient has no pain but also no life. Okay. Biomedical versus biopsychosocial. Traditional biomedical science, the X-ray you cannot see, just by medical surgery. The central sensitization because it is invisible. Okay, liberals biologists say basically that recognizes that the pain can produce pain even without the body, even when the body is healed. The invisible pain is just as real as a broken bone. They push for multidisciplinary care, therapy, social support, and meds rather than just waiting for physical reason to treat physical reason to treat the patient. Summary for your debate: primary goal, physical function, conservative approach. Pain reduction is the liberal approach. Your opioids, the last resort, a necessary tool for human rights. Sources of truth, objective data, subjective reports. Pain is the subject. Pain is what the subject says. Overexposure to substance, social. Okay. And that I think is a good end to the video.
All 4 of these
I'm just going
medications can be tried
to.
in
Should I
turn.
push it 1 hour? No,
Own-
let's just keep it not 1 hour. And I'm going to stop recording. No.